And now we'll be moving on to our last section of this topic, that is the connective tissue disorders. We have gone through the stool diseases, that is the accumulation of glycosaminoglycans. We've gone through the tumor-like conditions, but now we'll be, as in a joint, there's not only bone, they're associated other structures as well. And connective tissue forms a very important part of the musculoskeletal system. So we'll be going through the three syndromes which mainly affect the collagen, which is formed the basis of connective tissue. We'll be going through the Ehlers-Danlos syndrome and Marfan syndrome, which are purely collagen deficiencies, and then certain familial B protein deficiencies such as Larsen syndrome. So coming to the first, what is Ehlers-Danlos syndrome? It's actually one of the connective tissue disorders, and it is a disorder of collagen synthesis. That is, certain type of collagen may be defectively synthesized, as it is actually associated. If you see this over here, this is one form of a Burden scoring is being done, which is showing some degree of hyperlaxity. These patients usually have hyperlaxity as well. In Ehlers-Danlos syndrome, this is actually a group of inherited disorders caused by abnormality of collagen formation and proteins responsible for normal collagen. There may be different types of collagen. There are almost from 1 to 13 different types. Usually the 5, 1 and 9 types are mainly affected in this disorder. This includes the features of this disorder usually include problems with the skin, such as fragile skin. There is a joint hypermobility because of their generalized ligamentous laxity. There may be a vascular fragility because these collagen, which is present in the which forms part of the connective tissue of the vascular system, is also defective and associated with severe myalgias. Clinical features include they may be associated with variable inheritance patterns. Some are autosomal dominant, some are autosomal recessive. Mainly it's autosomal dominant, but also the other autosomal recessive forms do exist as well. Mutations include collagenase genes they call 5A1, which is for type 5 collagen. 5A2 is also for type 5 collagen. Then call 1A1, that is also for type 1 collagen, and call 3A1, that is for type 3 collagen. So it's mainly basically the different types of collagen, type 5, 3 and 1, which are defective, and usually they are present in the skin and around the vascular connective tissue. This is the clinical other features include actually the cardiac anomalies, which may be most commonly it is the mitral valve prolapse, elastic skin and bruising tendency, congenital talipes equinovarus may be associated with them, progressive kyphoscoliosis, and dysplasia of the hip and patella and femoral instability may be associated with increased myalgias, musculoskeletal pain, and osteoarthritis of the knee joint. So management, as you know that it's a genetic disorder, so the treatment would be directed against the complications. If it, for example, patient is an osteoarthritis, then we need to do the knee replacement. If the patient has a hip arthritis, probably that would require a total hip replacement. If the patient has scoliosis, then probably needs spine stabilization in form of a anterior posterior fusion. So if it is that is actually addressing the painful and unstable joints may sometimes mean orthodesis as well, because the joints may be so hyperlax because of the ligamentous laxity that eventually instead of performing a boning procedure, orthodesis may be a very good option in this disease. Other include physiotherapy, spinal fusion if the scoliosis is present, surgery depending upon what kind of a problem it is. That is, whatever the complication is, you have to address it surgically. But actually we are not addressing the disease, we are just addressing the complication of the disease. And why there are associated complications associated with surgery as well, because we know the problem is with the there's a genetic problem that the connective tissue and the collagen which is defective. So even we are addressing the complications during surgery, but we'll still be having some kind of a problem because we have not addressed the disease itself. And this is usually increased bleeding tendency due to fragile skin. There's excessive bleeding because the connective tissue falling in the vasculature is also defective. There's increased vascular fragility, which also leads to further increased bleeding tendencies and then increased chances of petechiae, and hemorrhages in the skin. The diagnosis of this disease is actually based upon the ligamentous laxity, biochemical and genomic analysis of the collagen. Ligamentous laxity can be calculated by use of pattern scoring usually, but this ligamentous laxity may be present in other number of other causes. Now coming to the second syndrome, which is called as Larsen syndrome, it's actually also a heterogeneous condition caused by an abnormality in gene coding for filamin B, a cytoskeletal protein as well. So it's also actually for part of a protein which is actually present in the collagen, which once not there, this will further result in skeletal and joint abnormalities. Major cases are autosomal dominant, and the clinical features includes hypermobility and hypertaylorism, multiple joint dislocations. Why? Because usually they have a ligamentous laxity associated with them. Nasal bridge is flattened, as this can be classically seen in this child. Prominent forehead and cervical kyphosis, and there may be associated foot talipes, that is the foot may be having a talipes equinus, that it presents like a horse tail, and the usually associated short stature and cardiovascular abnormalities may be present in these children. So diagnosis and management, as we know, it's a genetic disease. Again, the management is directed against at the complications. The diagnosis by actually as far as cervical spine and radiology. Neonatal ultrasound of the hip may show these pathology as well. Management is what depending upon what kind of a problem it is. If it is spine is going into kyphosis, or the thoracolumbar kyphosis is getting marked, then may need a spinal fusion. If for example there is neurological involvement, this may result in decompression of posterior fusion to relieve the nerves of the neurological instability and compromise. If it is fracture, this may require a close reduction. If it is a dislocation, this may need a close reduction, especially in children. If it is fracture, then it may initially can be managed in a closed reduction, but if not, then probably would also require an open reduction and realignment osteotomies, because multiple fractures eventually lead to angulation. There may be multiple ways of managing these complications, which also require open reduction and nerve fixation, closed reduction and serial casting, which may be also required in case of recurrent knee dislocations. If the patient has a femoral instability, this may require open reduction with femoral shortening and osteotomy at distal femur. There may be also soft tissue reconstruction may be required, because they usually have a generalized ligamentous laxity, and ligamentous augmentation may be required to stabilize the joints at times. Now lastly, we'll be coming towards another syndrome called as Marfan syndrome. You see this lady in the picture. Can you appreciate how long arms she has? And if you see the hands, she has a very long fingers, long arms. This is classically diagnosed by these patients have usually very long upper limbs and long hands and feet, but usually this height is not that long. So usually it's an autosomal dominant disorder, which is actually characterized by mutation the fibrillin type 1 gene, that is FPN type 1 gene, which affects mainly the musculoskeletal system, the ocular system and cardiovascular system. So they have problems in the eyes, they have problems in the heart, and they have problems in the skeleton. And if you see it, the hands can be appreciated how long the fingers are. Usually the features include they're tall and hypermobile due to ligamentous laxity. They have long limbs and digits. They may be associated with scoliosis and pectus excavatum. There may be associated femoral head protrusion. They may have a planovalgus foot deformities as well, that is they may have a flat foot. Recurrent joint infections and dislocations may be common. Extraskeletal manifestations may also be present as well. They may be, as they have ocular abnormalities as well, this may result in superior lens dislocation, pneumothorax, and aortic root dilatation in case of cardiovascular anomalies. So they have usually the problems are grouped into three categories, that is the ocular, cardiovascular, and musculoskeletal. May have a dural ectasia as well. Diagnosis is actually based on after screening these patients, especially those who are tall and really have long fingers. On the basis of clinical findings, then echocardiography, they will show mitral prolapse and problematics. Then usually the surgery is directed against the complication. For example, if their spine is going into some kind of a kyphosis, then probably fusion may be required. If they present with pathological fracture, then we may have to treat that. Or if they present with ocular abnormalities such as superior dislocation of the lens, then probably surgery regard to surgery for the lens may have to be performed. Or if they have presented with some kind of a hip or knee dislocation, then probably we have to go for a close manipulation and close reduction of these dislocations. So depending upon what kind of pathology it is, this treatment is directed at the complications, not to the disease itself, because we know it's genetic and we cannot change the genetic component of the disease. So what are the complications despite being as it's a connective tissue disorder? So usually despite treating them adequately, this will eventually result in a lot of complications such as wound infection. There may be hardware failure, there may be pins may migrate, there may be social screws may get dislodged, or despite, for example, if spinal fusion was performed, despite having the fusion, the upper segments and the lower segments may again be going into the kyphosis, and then maybe require a redo surgery. They usually may develop pseudarthrosis, that is the non-union of the long bones, and hip pain due to protrusion. And acetabular abnormalities may also be present due to recurrent dislocation, and there may be associated joint instability, which will not only present despite multiple close reduction, they may have a joint instability and easy dislocatability of the joints, especially the knee and the hip. They may have a feet abnormalities as well, which may need osteotomies or may need some kind of splintage to correct them. Now in this section we have covered certain connective tissue disorders as well, and we know that they are usually those disorders which have a genetic component, and due to genetic component these patients may present with generalized ligamentous laxity as well as certain the cardiovascular abnormalities. The main aim of the treatment is actually direct against the complication. If something is going wrong with the spine, correct it. Something going wrong with the joints, we need to correct that. But the main aim is not actually the disease itself, rather at the complications and managing the complication of these diseases. But again, as the main disease is still there, therefore all the surgeries of these diseases, usually the Ehlers-Danlos syndrome, Marfan syndrome, and Larsen syndromes, which eventually result in some kind of a complication because the main genetic component of the disease is not been eradicated. Thank you very much. Keep watching sqadia.com.